We made it. We weren't sure for a moment there.
Well, we're here. I lost track of time.
Listen,
It's my fault. I was working and just trying to get something done. And I looked up, it was 4 o'clock. And then the next thing I knew, I'm getting a text. And I'm like, oh,
Like, are you coming?
okay. Better late than never, right?
right.
That's right.
We'll go with
That's
that.
right. That happens. You get very immersed in things and then
Yes.
time just flies. So awesome. Good. So anyone who's new, just to recap, we are going through this book. It is a medical textbook.
Yes.
Ketogenic, the
A
science of
complicated book.
carbohydrate restriction and human health. It is very, very meaty, pun intended. And,
I like that pun. I like
yes.
that.
And unlike our book club, we do not read ahead. We read and review as we go on our live stream. So, anyways,
And I love that because I like to not have to be super prepared, just show up.
Right.
Yeah.
I love that.
Yeah, and it's actually super interesting to kind of see how our brains can process the information as we read it.
Yeah.
And usually when you read a textbook or just read any other book and you're by yourself reading it, you can take notes in the margin and stuff, but sometimes those ideas and the questions that pop up and you don't want to let them go. You want to start, talk about them right away.
Exactly. Yeah.
So, yeah.
And, sometimes I might sound like a dummy because I'll say something and then I'll watch it back and I'll be like, oh, that wasn't what that meant at all. Or it seems like everybody else got it, but you didn't.
But you know what? That's okay. It doesn't sound dumb to us.
No.
I don't, at least not to me.
Well,
we're
we're
here
not
to learn. That's the whole
know?
point. We're here to learn. And, I probably ask the dumbest questions, but I always tell, like there's a new guy that we have at work, and I always tell him, ask. No question is a dumb question, no matter how dumb you might think it is. Ask.
That's right.
I'm going to ask. What does that word mean?
Yeah. And we have some amazing people who join us online who can often help clarify things for us. So we're happy about that. Hey there, Josephine. Good to see you here. Okay, so we left off. We are in chapter 2, and we left off on page 79. And you know what? I had forgotten last time that I actually have the slides. So let me grab those and have them. Yeah, and have them ready to go. I think we're on
table 2.4. Yes, 2. That one.
4. Yeah, and I think that was actually we read about that last time. So maybe it'd be good to maybe do I'll just read the last little paragraph of last time that refers to this table, and then we can just take a look at the table and make sure we didn't miss anything important. But this last section had to do with contraindications to a therapeutic carbohydrate restricted diet. So it says the only absolute contraindications are porphyria and inborn errors of metabolism. And this is where this table comes into play. So it says here, these are the absolute contraindications. So a carnitine deficiency and carnitine associated enzyme deficiency. So the complication would be defective ketogenesis and fatal hypoglycemia. Holy cow. So
wow.
How does a person know that they have a carnitine deficiency?
You would definitely know very early in life.
That's the one that's early, that they find out when they're little. Okay. I'm
never really good. Because I'm like, wow, that's scary.
Okay, so basically anyone who knows that they have a carnitine deficiency should not be doing this diet. Acute intermittent porphyria. So the complication would be carbohydrate restriction induces relapse of the condition. So it can make your porphyria worse. Mitochondrial fatty and B oxidative disorders, which have the same complication as the carnitine deficiency. Again, do you know anything about that, Kim? And like, you know,
no.
Okay, and then
but it's just something that you would definitely know.
Probably would know. Hopefully would know. And then pyruvate carboxylate deficiency, which hopefully you would know that as well.
And that has something to do with the what's the Krebs cycle? You know, the pyruvate and anyway. I'm not going to pretend like I fully comprehend all of that, but
I've heard it referred to, but I don't quite. Yeah. I mean, I don't know it in detail, I guess is the point. Yeah. I've heard it talked about.
But yeah, these are like genetic disorders.
Genetic. Yeah. Okay, so I'm just curious to see. It's a disorder. The pyruvate carboxylase deficiency is an inherited disorder that causes lactic acid to accumulate in the blood. It's a rare condition with an estimated of 1 in 250,000 births worldwide.
Yeah.
So, and actually, this is type A of the disease appears to be much more common in Algonquian Indian tribes in Eastern Canada, while the type B disease is more present in European populations. So I would imagine, so it causes lactic acidosis and hyperammonemia, can lead to liver failure, enlarged liver, reduced ketone body synthesis. There you go, and demyelination of neurons. So obviously, this is something, if it's inherited, you're going to probably have parents that know they have it. Infants with this form of the condition usually survive less than 3 months after birth with the type B. And so it's children, and then with the type A, children with pyruvate carboxylase deficiency type A typically survive only into early childhood. Wow. So so very, very probably there aren't any adults that have this.
Yeah.
Okay. All right. Well, that was interesting. Okay. I just wanted to make sure we reviewed that slide since I missed it from last time. So, okay. All right. Do you guys just want me to, let's see, where do we leave off last time?
We left off right below the table.
Okay. I'll start then. So, and I don't have to worry. I'm completely over my flu now.
Oh, goody.
All right.
Yeah, so I don't have to worry about, stressing out my congested sinuses and my voice. Okay, so we left off at section 2.2.3.3, which is kind of a main section called potentially serious adverse effects and troubleshooting. And then the little subsection below it is dehydration and loss of sodium and potassium. So TCR, or therapeutic carbohydrate restriction, can initially cause water loss with concomitant loss of sodium, potassium, and magnesium. This contributes to weight loss in the first 1 to 2 weeks, but can lead to dehydration, fatigue, hypotension, lightheadedness, headaches, difficulty concentrating, and muscle cramping, also known as the keto flu. Water loss is caused in part by increased glycogen use because glycogen is stored with water, and water is released during glyconeogenesis. The other part is due to lower insulin concentrations, which signal the kidneys to retain water and sodium. In those with medical conditions, especially those taking diuretic medications, it is important to be sure that blood electrolyte concentrations, so sodium, potassium, are normal before initiating a change in diet. Replenishing water and sodium adequately can prevent and/or minimize the above keto flu symptoms. For hydration, a rule of thumb is to drink about 1 liter of water for every 32 kilograms of body weight, or half one's weight in pounds, in ounces of fluid per day, up to approximately 100 ounces. So that's interesting. So there's a couple of thoughts I have on this one. And then I heard a lot of people say that when you're starting a ketogenic diet, whether it be keto, carnivore, or whatever, you really only need to replace sodium, that you don't necessarily need to have the sodium, potassium, magnesium electrolytes. Had you guys heard that?
I've always experienced that.
Okay.
I've heard that, and I've also experienced that to be true. And my old standard go-to was always a cup of chicken broth twice a day to transition me into. And I mean, I'm not saying that the chicken broth doesn't probably have other stuff in it, but I don't know.
That's a really good thing to do, though, is to do the chicken broth. I remember back while I was still working, I remember one of the doctors just told me chicken broth is as good as IV fluids.
Yeah, it really is.
Yeah.
I mean, I just know that from experience, like totally not from, anything else, just personal experience.
Oh, yeah. And I mean, go ahead, Carrie.
Well, I was just going to say, I would think, now maybe I'm misunderstanding what they're saying here, but I had always heard too, though, that if you drink a lot of water, you run the risk of your electrolytes becoming out of balance. So maybe they say something.
I'm really glad here that, this really clarifies to me, because I've heard people say you should drink 1/2 your body weight in pounds, but this puts a cap on it. And I have 100 ounces, and I haven't heard other people put caps on it. And like when I was 350 pounds, I was going, seriously, you want me to drink 150 ounces of water a day?
That's
be
crazy.
Floating. We'd all be floating. I don't think I could drink 100. I mean, half my weight. That's awful lot of water. Maybe I do, though, because I do drink a lot of water. But
well, yeah, my naturopathic doctor suggested that I try to get 80, which is still, that's probably more reasonable,
Yeah.
But a lot of doctors will say drink 8-ounce glasses of water a day, or, so that's 64 ounces. So, but maybe this is kind of what you need to do when you're transitioning onto a ketogenic diet. It's just to make sure, because you can get dehydrated. So maybe drink extra fluid. And I like the whole chicken broth thing much. Yeah, I think. Yeah. And, when I was working in outpatient nursing, and so much of my job was on the phone doing like triaging and managing patients over the phone. And when you have someone, at home, and I've done my, assessment over the phone, and I can even like have them take their blood pressure and do orthostatic blood pressures and, checking their pulse and all of that. And, when I suspect someone is dehydrated, most people have chicken broth in their cabinet. And so that was a go-to, like drink chicken broth. And so many times people would say, oh my gosh, yeah, that totally just did the trick. So
look at the next paragraph.
Yeah, I'll keep reading. So electrolyte, here we go. We were just talking about that. For electrolyte replacement, bouillon or broth is an efficient source of water and sodium.
Kim was on it.
There you go. That's right. Nurse Kim, she knows what to do. 1 to 2 cups daily is recommended. No calorie sports drinks or other calorie electrolyte solutions are alternatives. Certain patients, however, should avoid drinking broth or other high sodium electrolyte solutions. In patients with congestive heart failure, uncontrolled hypertension, or chronic kidney disease, additional sodium could exacerbate their chronic conditions. In these unique cases, reduction of diuretic medication instead of increased salt intake is preferable for preventing dehydration. So again, work with your doctor. For patients taking larger doses of diuretics, in-person or virtual clinic visits every 1 to 2 weeks may be necessary at the beginning to minimize the risk of dehydration. Symptoms of keto flu typically resolve in 7 to 10 days, whether or not these preventative measures are used. During this transition stage, heavy exercise should be avoided, and exercise can be resumed thereafter. Adequate nutrition should be emphasized regularly. Increased sodium intake may only be necessary in some individuals and may be continued as long as elevated blood pressure and swelling do not occur. So that's very good. Okay, I'll stop there.
Okay, I can go next. Okay, the next section is 2.2.3.3.2. Try saying that 10 times. Over-medication in individuals with diabetes and hypertension. People with diabetes can benefit greatly from TCR, including improved glycemic control, reduced medication requirements, fewer hypoglycemic events, and lower distress related to diabetes. These improvements can occur in people with type 1 and type 2 diabetes, but there are precautions that practitioners should take to reduce the risk of hypoglycemia in anyone taking insulin or insulin secretagogues. So these are well, I don't know how to pronounce that.
Sulfonylureas. Yeah.
Sulfonylureas and meglinotides.
Sulfonylureas.
Yeah, sulfonylureas.
Sulfonylureas. Okay,
sulfonylureas. Say that 10 times.
And meglitinides, right? Meglitinides. Okay. To reduce the risk of hypoglycemia, doses of these specific medications should be reduced on the same day as diet initiation in comparison to recent glycemic concentrations. So see Chapter 3.3, Adapting Medication for Type 2 Diabetes in the Context of Therapeutic Carbohydrate Restriction. Patients taking these medications should monitor serum glucose. See Chapter 3.2, Type 2 diabetes, where structured glucose monitoring is detailed on a regular basis. So in other words, let me start this sentence again. Patients taking these medications should monitor serum glucose on a regular basis and be able to easily access their healthcare team for assistance with medication adjustments if necessary. For patients taking higher doses of insulin, in-person or virtual clinic visits every 1 to 2 weeks may be required at first to ensure safety. When blood glucose levels are under control, weight loss is slowed, and hypoglycemic episodes are rare, visits may become less frequent. While patients are adapting to TCR and losing weight, blood glucose concentrations in the 8.4 to 13.9 millimoles per liter, or 150 to 250 milligrams per deciliter range, can be tolerated soon after medications are reduced in order to provide a cushion from hypoglycemia episodes. And I really do think it would be very important if you take insulin. Yeah, you need to do this with your doctor, because trying to do that yourself would be it's a very delicate thing, and you might miscalculate, and that can be dangerous. I mean, my mom was pretty good at it, but every now and then, and of course she was having carbs, but it's kind of the same principle. And I think a lot of people go through it where you just calculate wrong, and you really can have, have hypoglycemia, and, you have to grab something, have to grab something with sugar really quick in order to bring that back up. It could be dangerous.
Yeah. Although, I've found that there's a bit difference as far as just my interaction with patients with diabetes. There's been a big difference in patients with type 1 versus type 2 diabetes as far as their ability to manage their blood sugar. People with type 1 diabetes have it dialed in.
Yes, they've got it down.
They have got it down. Yeah.
I mean, where a person with type 2 should, but people with type 1, it's life or death, because they don't make any insulin at all. So they have to really get it right.
Oh, yeah. And, so often they're like, they manage their own, their doctor, they work with their doctor, but so very often they're like, hey, I know how to manage my blood sugar. And although I still think that, if you've got type 1 diabetes and you're changing your diet, you do need to be working with your doctor. I mean, because it's going to affect your prescriptions and all of that. And a lot of them have a insulin pump,
Yeah. I think most type 1s have an insulin pump.
Yeah.
Everyone I've seen has.
Yeah, me too. Yeah.
Mm-hmm.
So interesting.
Okay, and then the next section is 2.2.3.3.3, elevation in total cholesterol and LDL cholesterol. One of our favorite topics. Okay. TCR has had a variable impact on LDL cholesterol, LDLC, in clinical trials. On average, low carbohydrate nutritional interventions used for weight loss do not increase LDLC from baseline, but increases have been reported in some trials, particularly in comparison to low-fat eating patterns and in individuals. There are physiological reasons for the uncertain effects. Firstly, low carbohydrate eating patterns are typically high in saturated fat, and saturated fat intake is an important modifiable predictor of LDL-C elevation. On the other hand, lower carbohydrate intake decreases insulin concentrations, which in turn inhibits HMG-CoA reductase and therefore cholesterol synthesis. Given the amelioration of good grief, Carrie, get it together. Given the amelioration effects of low carbohydrate nutrition on serum triglycerides and HDL cholesterol, HDLC, particularly when compared to high carbohydrate, low fat eating patterns, the overall impact on risk appears to be a reduction, but this will not be known definitively until a clinical outcomes study is performed. So it sounds, in a sense, like they may be talking a little bit about and I've heard this before, that if you're losing weight, some your cholesterol, your triglycerides can go up because there's more fat in your body, but that your cholesterol doesn't dramatically rise so much as it does like if you're like a lean mass hyperresponder. Of course, it goes up. I don't know. That sounds like
I've experienced just the opposite with the triglycerides. Like if I'm not eating carbs, my triglycerides are low. Like, and my mom is a laboratory technologist, and she always told me that, like, people who have high triglycerides, they eat a lot of candy and stuff like that. And I didn't know why that was so, like, but it didn't even really make any sense because it sounded just the opposite of what you would think,
Well, because we were taught it was fat.
Huh?
We were taught it was fat, not sugar.
Yeah, I know, but that's not right.
Right.
And I think it's because when sugar breaks down, like a sugar has like I don't know. It's like the chain, like one piece of it breaks off and then what you're left is like 3 fat molecules, or I don't know. I'm sounding really ignorant right now because I don't know how to explain it, but 3 glycerol molecules or something like that.
Yeah. I think you're right. That sounds
I don't know. I don't even want to verbalize it because it sounds so stupid because I don't know what I'm talking about. But I have heard that, like, that was wise because it's the way that the sugar's broken down, maybe. I don't know. Help. We need a biochemist.
Yeah, I don't know.
We really do.
I'm just a nurse, y'all. I'm just a nurse.
Yeah.
I barely have a bachelor's degree, okay? It was just because they made me go back and get it.
Yeah, I got one too. I actually started my master's degree and they didn't go into this much detail, right? They're like, just this is what happens to, this is their symptoms. And, we study pathophysiology, but it's like, this is a lot of detail.
I think maybe what I'm thinking of is, and I believe we talked about this before, Dr. Davis, I used to follow him a long time ago, and people would, like ask questions on the Facebook page about, like their lipids and why their triglycerides were still higher and stuff like that. And he would say that, especially when you're first starting, like if you don't give it enough time, that if you get your blood work done too soon, then your numbers are not going to necessarily reflect what you've done with your diet, is what I'm thinking of. But
okay, guys, if I look distracted, it's because there's some shady people around here.
Oh no.
I'm gonna roll up my windows, okay?
Okay.
So, and I have to get out of the car to do that. So just like keep talking for a minute, and I'm gonna stop my camera.
Okay. Well, my LDL went up. And
how long did you were already on keto though, right before you went carnivore, or did you just jump into carnivore?
It had been a few years since I had done keto for a couple of years, but then there were several years in between where I was just eating garbage and tons of sugar, tons of starchy carbs, ultra processed foods. Yeah, my diet was terrible, and I really didn't eat very much meat. But my LDL, on the carnivore diet went up, which was fine because I got the fractionated test, and it's I have the big fluffy particles. But my triglycerides went cut in half.
Yeah.
And my HDL has been trending upward in the right direction. So it's
you're
back.
So how long after
what?
You got your gun?
Well, I need it because there are, I don't know if you guys remember, there was one day when a guy literally just walked up to my
scared you.
And I think he was just probably wanting to ask me for some money or something. And I'm not scared of people like that. But these guys were literally, well, one of them had a bandana. And people wear bandanas. I'm not trying to profile people, but they were literally showing each other some sort of, they were imitating each other, trying to do some kind of, it looked like gang signs. I don't know. It's crazy. I know it sounds.
No, it's not. And if your warning bells are going off, they're going off for a reason, I think.
They weren't paying attention to me at all, but I'm sitting here by myself in my truck with the windows partially down, and I'm just I would feel more comfortable if I just lock the truck and put the windows all the way up. So that's what I had to do. So anyway, sorry about that, guys.
That's okay. So Josephine says, sadly, I'll be going soon. Doctor's appointment.
I think she's going for her doctor's appointment. She doesn't want to go.
Okay. Hope all enjoy a beautiful day. Awesome. Glad you could stop by, Josephine.
Yeah.
Hope the doctor's appointment goes well. But we'll definitely trust your instincts, Kim.
What?
So many factors.
Definitely trust your instincts.
Yes, yeah. For sure. I'd much rather, people can think what they want of me, but if my warning bells go off, that's just it.
Yeah, I've been around all kinds of people, and these guys were probably just some kids playing around. But, and by kids, I mean 20 somethings.
That's old enough to cause trouble.
I know. They're probably harmless, but I have to protect myself because I don't know them. So,
right.
All right.
So, okay. So we're in the middle of the
so I'll go ahead and
yeah.
I can finish reading this part here, but I guess what it is, it's all different body types and different. I was going to ask you though, Lynn, how long after you had started carnivore did you get your blood work done the first time? Where you noticed that it went down?
It was quite a while before, after I started. I think it might have been close to the 6-month mark, potentially. So
and that's good. That's what I've heard, is that people should wait at least, 6 months. And for some things, you could do it a little bit sooner than that. I've heard Dr. Berry tell some people, test again in 3 months. But I think sometimes, if however your physical gets scheduled, and you have to go in. And so say you've only been doing it for 3 weeks, or a month, and, it's time for your physical. So if you don't reschedule it, then you go in and then your blood work looks crappy. And it's just because you're in a transition.
And that's definitely important when it comes to the hemoglobin A1C.
Yeah.
Because the hemoglobin A1C covers 120 days of average of, your blood sugar. So it's good to wait. Hopefully you'll see it trending down, even if it's a month afterwards, because it should lower the average if your blood sugar is lower on a daily basis, but it's not necessarily what it's going to be. Yeah.
All right. So if LDL-C rises significantly, calculating the atherosclerosis cardiovascular disease risk score, which includes HDL-C, blood pressure, and other risk factors that may improve with low carbohydrate nutrition, can help determine whether overall risk has increased. In individuals without known cardiovascular disease, the ABCVD, in other words, that atherosclerosis cardiovascular disease risk score, is now the primary consideration when deciding on lipid-lowering medication therapy. Furthermore, lipid subfraction analysis, like what you were talking about, Lynn, for example, NMR cholesterol profile, may be useful in further defining risk. Prior research has shown that low carbohydrate nutrition typically leads to increases in the less risky large LDL-C subfraction, and a significant low carbohydrate nutrition typically, okay, goodness, okay, let me start that sentence again. Prior research has shown that low carbohydrate nutrition typically leads to increases in the less risky large LDL-C subfraction and a significant decrease in the riskier small LDL subfraction. Other tests such as C-reactive protein and coronary artery calcium CAC score may contribute to the risk assessment and inform the shared decision-making process with the individual. Okay.
I wanted to quickly go through, though. I looked up this score, this ASCVD score, just to see what the calculation is. I'm assuming all of these are relevant. Otherwise, they probably wouldn't ask. So they ask you your age, your sex, male or female, your race. I'm assuming that there's a race component to it potentially. They want to know your blood pressure, your total cholesterol, your HDL cholesterol, your LDL cholesterol, whether you have a history of diabetes, whether you're a smoker, current, former, or never, whether you're currently on hypertension treatment, if you're on a statin, if you're on aspirin therapy. And then the last question is, do you want to refine current risk estimation based on data use from previous visits? Yes or no, I don't know. But anyways, it asks you, these are all the things that go into calculating the score. So if you have all this information, you can go online and calculate the score for yourself. Yeah.
That's good to know. I was thinking, of course, I guess I was thinking about what Dr. Ovadia always, and others have talked about for the like how you evaluate your metabolic health and how it's factored into whether you would want statins. And for example, like if your CAC is 0, then it talks about your HbA1c, your triglycerides, your HDL, and then there's that calculation that you do dividing your HDL and your triglycerides to get that ratio. That's what I was thinking that was. So obviously I was.
Yeah, no, this is more detailed, and I don't know, like, yeah, and I don't know. I'm assuming that they ask you whether you're on blood pressure medication or statins and aspirin, just so that it can factor in that this is like a corrected number, and not a numbers off of medication. I'm assuming that factors into the risk score. Because, I mean, if your blood pressure is still high and you're on hypertensive medication, or your cholesterol is still high and you're on a statin, they probably consider you higher risk than somebody who's, not on those medications and still, and has high numbers. So, but I just watched a little video that someone sent me today that was talking about how, like, even like, I think it was like 40 years ago, that 300 or 350 even was considered fine with your cholesterol. And that it was like no big deal, not a problem. And now all of a sudden it keeps going down, 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 down. Yeah. And so they can put you on statins.
Yeah.
And I'm thinking about the blood pressure. Now I know the low number has been consistent, like what's considered normal, like 80, I think has pretty much always been. But for the top number, I had always heard that up until a certain age, and this is like a while back, it used to be that it was 100 plus your age for the top number.
Well, there's a lot of doctors that cardiologists that'll be like, permissive hypertension is okay, especially if somebody has had strokes in the past because they want to make sure that they get blood flow to the brain, at least cardiologists I've worked with, but it depends on the person. And but older people, a lot of the doctors will say, yeah, if it's in the 140s and the mid 80s and you're 70s in your 70s, they're not going to worry about it.
Yeah, I'm gonna have to look that up. Like I will, I'll forget. But anyway,
so I don't know. Kim, you work currently with patients. Do you hear anything with the doctors nowadays about who they are okay with having a little higher blood pressure?
I mean, definitely a neuro patient.
Mm-hmm.
Like you want to perfuse that brain,
right.
So they would be more permissive with that. Also, they're more permissive in the acute care setting, like where I work, where we're sending people home after surgeries. Like somebody comes out and their blood pressure's in the 170s, 180s. We don't love that, but if they didn't take their blood pressure medicine today, and this is like where they live, we might be like, okay, well, we'll give them this, and then when you get home, take your blood pressure medication. It's not like they're like, oh my gosh, it's not stroke level anyway.
Right.
So that would be something that if someone has 170s, 180s, and they're on up in age and they've not had a stroke up to this point, I don't know. It's just, you just have to look at each individual person. Like if I was in the 170s and 180s, my doctor would probably be freaking out because, well, there's so many factors involved in it.
But for your age too, it should be lower.
That should definitely be lower. And when any of our criteria is all based on people that follow a standard American diet for the most part. So, for us, what's okay with us in the ketogenic space is not going to be the same, and even like for me, if my blood pressure's in the 130s, that is extremely high for me. Okay. I usually run around, 110. So, I mean, so with my words, I'm a little bit dramatic. So if I say extreme, like it's not really extreme. It would be high for me. Let's say I need to watch my wording, especially on YouTube, because people don't know me. They don't know my personality. I'm an exaggerator. So let's just say 130, I would be feeling like awful. Like I would be feeling really bad. Okay.
Well, when I had to call 911 the one time, one of the times where I had a mast cell reaction and, the EMTs came in, of course they check your vitals when they get there to your house, right? My blood pressure was 220 over 120.
Oh Lord, that's stroke level.
That's stroke level.
No.
Yeah. That was a hypertensive crisis, but it was a mast cell reaction issue.
Yeah.
So for me, you're not going to give me antihypertensive medications. You're going to give me histamine blockers.
Well, and that's another thing you have to consider. Like when we look at a patient that's come out from the OR, often when I get them, if they're somebody who has a history of hypertension, when they're fresh out of the OR and not even awake yet, their blood pressures will be like 180s, 190s. And some of the younger docs, they'll be like, oh, kind of, well, do you want me to leave you something to give them? And I'm like, let them settle.
Yeah.
Okay. Just give me a few minutes with them. I'm going to let them settle. And it almost always, like, not that I'm smarter than these doctors, but I just have more experience at the bedside with the patient. I know what happens.
Right.
You know what I'm saying? I know what happens after they leave. Within 15 or 20 minutes, generally it'll settle out, and it's just like all the medications they've been given, their body's under stress, they're probably in some pain. It's so many factors go into your blood pressure. You can't just look at one number, and a doctor will tell you. You call a doctor and say, doctor, this patient's blood pressure is 180 over whatever, they're never going to say, oh, let's freak out, right? Because okay, measure it again here in a few minutes and see what it is.
Right.
It's never a stagnant number. If you have somebody with a arterial line in their arm that measures their blood pressure, you can see it's ever changing, just constantly changing. So,
yeah.
I Googled it, and this is what AI says. So I haven't like gone to any links, but it says it goes like in 1950, normal blood pressure was 140, 150, or 160 millimeters of mercury systolic and 90 to 100 millimeters of mercury per diastolic. And then in the 70s, they considered blood pressure normal if it was below a patient's age plus 100. Then in 2017, the American Heart Association and American College of Cardiology lowered the threshold for high blood pressure to 130/80 for all adults.
Really? What year was that?
What year?
2017. But back in 1970s.
Well, nobody's told us in the medical system. We still say 140/90 is technically.
Yeah, 140/90 is, yeah.
So they set, then it goes here, this was a change from the previous guidelines, which set the threshold at 140/90 for people younger than 65 and 150/80 for those 65 and older.
But see, we don't read. We don't read.
Yeah, I'm just saying, I remember your age plus 100, and I'm thinking it was Dr. Berry who had mentioned it, but I wasn't sure. But I was just curious because it just goes to show, like with medications too, I think there was some encouragement to lower that requirement so that more people would be on medication, basically. Is my conspiracy theorist theory.
Right. But it does make you wonder because they've done the same thing with statins.
Yeah.
You know, you get more people. I mean, think about it. If you're 30 years old, you know, it used to be that your blood pressure was okay to have a blood pressure of 130 systolic. Mm-hmm. But nowadays, for a 30-year-old, they expect it to be below 120.
Yeah, or 120. Yeah, 120 is the, well, yeah, I guess this says 130/80, so for all adults, but I don't know. And then
they keep messing with the numbers. It was for a while it was under 120 and over 80 needed to be below that, and they keep kind of adjusting the numbers.
Yeah, and you have to consider, like, what I'm saying is acute sick setting. Okay, they're either sick or they've had surgery. So like, this is not the normal just you walking in your doctor's office, hey doc, what's up, let me sit here and chill for a few minutes, then get my blood pressure. This is like our bodies are in a stressful situation right off the bat. So like, you know, those are two different situations,
right? But in the outpatient setting, 140/90 is the cutoff for, this is our medical assistants. When I worked outpatient, there was 140/90 was the cutoff for them needing to recheck the blood pressure before they let the patient go home.
Yeah. Well, our standard is 160 or below for whether or not we treat it in the acute care, like sick surgery setting, you know, sick surgery setting, triple S. So what we do is if they're below 160, we pretty much don't sweat it. If they're above 160, we may say, hey doc, do you want to give, you know, hydralazine or labetalol IV to get this down? Or do you want to just say, hey, the patient hasn't had their blood pressure medicine today, let's go ahead and get that in them, you know?
Yeah, they're definitely more permissible hypertension in the hospital because of the situation is different.
Yeah, and I would think that's logical because your body has, like Kim said, well, and you both of you have said that it's stress, and so you need that extra flow to kind of, you know what I mean, to just to nourish you or whatever. That's how I would think of it. I could be wrong.
Yeah, perfusion. I mean, you need oxygen perfusion to your brain and all your vital organs. So permissible hypertension is often.
We worry more about low blood pressure. Now, if you start getting low, we're like, oh.
Then you're worried. Yes.
Yeah.
So just out of curiosity, what do you do for low? Like if
It
somebody
depends
does
on how
say,
low. The first thing that you would normally do would be give them a liter of fluid. Just depending on, I mean, there's a lot of factors and situations and conditions of the body that go in, but just your standard, like healthy person, let's say you were in the hospital, Carrie, and you were low. First thing I would do would be give you a liter of fluid, just quick as I could get it in you. And then at that point, if you're still low, we got something wrong here. She may be septic, in which your vessels just dilate out, and it's not an effective like pressure to get it back to the heart, right? And then you also start weeping into the third spacing, which is outside of the vessels, so people just swell up like, just fluid. But at that point you want a pressor,
there's vasopressor medication to help constrict those vessels to raise the blood pressure.
So we would start
thank you. I was just curious.
And then, until your body is healthy enough and we've given you antibiotics to fight that bacteria that's, causing your body to go into a septic shock state. Because that's what that is anytime your vessels are dilated out like that, it's like a shock state,
But post-surgical, it could be a bleed, right? I mean, you got to identify the source. I mean, blood pressure dropping you got to figure out why.
So many different things could cause it, but those would be the first steps, regardless of the source.
Right.
Is
get it up.
I'm gonna get it, and then I'm gonna be simultaneously drawing some labs to see what your H&H is, your hemoglobin or hematocrit, to see if you are bleeding, because you probably did just come out of the surgery, so anyway.
All right, well, thanks for bearing with my questions. I told you I would ask. I was very curious.
I try to overcomplicate it.
Medicine.
Sometimes I try to explain things, but then it's like, there's so many different things here where people could be like, no, you wouldn't do that because you would,
that's why, where hospitals are needed for urgent critical care. I mean, we don't. I mean, as we talked about that a lot, we're not
surgery,
Oh yeah, I mean, we're not completely against the whole medical establishment. It is needed.
Oh no.
Oh yeah, for sure. Yeah, you definitely. I mean, there are acute situations that you have to deal with, whether it's an accident or just, I mean, any number of things that can happen that, and so heck yeah, I'm happy for our modern medical technology in that way. It's just the chronic stuff is what irritates me, because so much of it is preventable.
Yes, exactly. And I'm not against the medical establishment at all in any way.
Right. I'm not either. But
I just hold them to a higher standard, and I expect a higher standard.
Yeah.
And if I don't get that, you're damn right I'm going to criticize you. I criticize a doctor and a nurse all day long, baby, because I'm there and I know. I know what you're supposed to be doing. If you're not doing that, sorry, if I went to even McDonald's, I would expect that my Big Mac would look like a Big Mac. Not that I would want to eat a Big Mac, but you know what I'm saying?
Yeah.
There's a standard for a Big Mac. There's a standard for the care that you provide me, and I also try to hold myself to that standard. So, it's not like I'm being a hypocrite. I'm going to take as good of care. I'm going to take care of you just like I would my mom or my dad or my cousin while you're there with me. So I just expect that,
But we're also
well-read, read up on recent studies and things.
And that's the thing that I think that we tend to be more critical of, is the fact that we have learned so much about nutrition and its effects on the body. And it can be frustrating when the people that are supposed to be taking care of you don't know these things, or they're turning a blind eye because they're afraid to deviate because they're going to get in trouble, right? If they deviate from whatever the algorithm says and whatever the guidelines say. So that's where the frustration for me comes in.
Definitely.
Yeah, I think a lot of it, like when my mom was in the hospital, before, this was the time she went in, before she went in during COVID. But anyway, and it was always the plate that they would send. I mean, I think the hospital she was at the time was probably better than a lot of them because there were meat options that she could eat, but they also she was a diabetic, and they would put bread and, a dessert and all this stuff on there. but she did have some meat and some vegetables that she could eat. And so, but the thing is, it's like, I hear so many stories and see the menu printouts and stuff of these hospitals where, they give them, like, for breakfast, it's cornflakes with orange juice and, a sliced banana and just this stuff. And this person's a diabetic. And I mean, there's not anything on that plate that they should be eating. And I've heard of some people saying that they don't have a choice. They actually gave us a choice, and things could have changed in that 5 years, since my mom was in the hospital at that time. But I mean, they would tell us, like, we could pick bacon, eggs, we could pick some things that we wanted on the plate. And then, so that was good. Yeah. They gave us a menu and with check boxes, and you could just
That's
check
what
off.
They do in our hospital.
But you know what's the most, like, in fact, my husband was just mentioning this the other day. What the hospitals are known for is Jell-O cups.
Oh my gosh, yes.
It's like, so you want some Jell-O?
Yeah, we have sugar-free, Lynn.
Yeah, there is sugar-free. But yeah, the Jell-O always.
I think there's nothing wrong with giving a diabetic a sugar-free Jell-O cup.
Sugar-free Jell-O,
if that suits their, their standard for what they consider, healthy for them or whatever. Like, some people consider that okay. I personally don't eat that, but I can't press my views on other people either, because it's still within the diabetic.
It's within there, yeah, and it is a clear liquid, so people who have to be on clear liquids is something that they can eat, but it's just funny because that's the typical, like, I've had patients literally who have been so irritated, like, I'll do shift report, and go in and talk to the patient, and they're just huffing and puffing because the nurse on the night shift didn't get them their Jell-O in time. It's like,
oh my gosh,
there may be someone in the next room that's not breathing, but you got to have your Jell-O, right?
But back in the 80s, Jell-O was just put up on a pedestal, like it was just the ultimate health food. I remember having Jell-O constantly in their fridge that was like not the individual cups, but where they had made it and put fruit on the
pan, like, and my mom was carnivore squares.
Yeah,
there's carnivore
Jell-O was like a big, health food back then.
Have you guys made the carnivore Jell-O?
No.
Oh, I have. I was eating too much of it before I realized that gelatin was high histamine. But you get beef gelatin, and you make it just like you'd make Jell-O with the hot water, but you stir in a packet of one of the flavored elements.
Ooh.
And then you chill it in the fridge for like 4 hours. It is so addicting.
That's it. I'm doing it.
It's amazing. I'll send you
that. I think I could do that.
Yeah, that sounds really
good. I think I got it from Lily Kane. I'll have to find her video where she tells you exactly like how much. I ordered the organic grass-fed beef gelatin through, I think, Thrive Market. But you can order the gelatin. So it's super easy to make. Like, it can whip up
oh my God, I'm so mad at Thrive Market right now.
Oh, okay.
I tell you, I signed up for them because they give veterans free membership. So I was like, I might as well get a free membership. I might see something on there I like. Well, I ordered a couple of times, and then I was like, this is just like, I don't need that stuff, and there's not that many things there that I can eat, right?
Right.
And so I just kept like putting it on pause. Well, evidently I put it on pause and I only had one thing in the cart. So then next time it came around, I didn't check I was super busy working for the last 3 days. They ended up sending me like this one thing that costs $8, and I'm paying $6 for shipping because I didn't add enough stuff. And I'm like, oh my God, now I'm going to have to pay almost twice as much for this thing that I could just go to the grocery store.
Right.
But it's my fault. I'm just like, dang it.
Well, then buy the gelatin somewhere else. But definitely it has to be the beef, good quality beef gelatin. But I'll send you the little video that I use to show the proportions and like the measurements.
Okay.
But yeah, super easy.
Well, I'm sure Thrive Market is fine.
Yeah,
It was my fault mainly.
I should make it again and see if I tolerate it better now that my gut is healed so much, because it was just the histamine thing with, and of course, it's like 40 calories for the whole thing.
And
so
actually, collagen helps it can help your gut heal.
Mm-hmm.
Well, it's a kind of a catch-22 with mast cell disease because it's all high histamine.
But I feel like you're healed more now, Lynn.
That's why I figured maybe I'll try it again.
Yeah.
And see. But like,
report back.
A 9 by 30. Well, actually, I would do like a square, like an 8-inch square casserole dish. I'd pour it in there and let it, and I'd eat the whole thing. It's like 40 calories for the whole thing.
Oh, wow.
And not that I'm counting calories, but
still, that's a lot of substance there, I think. Yeah. And I mean, it would satisfy a craving.
Yeah.
And I mean, sure.
Man, every now and then I crave something. Like every now and then I just want something that's like sweet. Just that, it's not all the time.
Right? Like Thanksgiving's coming up. You can make that, or you can do the little, like, cut it into squares, or you can put it in little glasses and then make some your own whipped cream out of heavy cream.
Oh, yeah.
And then put that on top of it and have that be like a little dessert for Thanksgiving.
Yeah, that's an excellent idea.
A carnivore dessert.
My daughter would fall over if I brought a dessert for Thanksgiving.
There you go. You can make that and and it can be a completely carnivore dessert.
Like, who are you and what did you do to my mother? Okay, so let's see. Okay, LDL cholesterol. I got us off on a tangent. I'm sorry.
Oh, I probably did too.
If a rise in LDL-C is a concern, then eating the plan can be adjusted to increase intake of non-starchy vegetables, leaner proteins, and unsaturated fats like olive oil, avocado, and nuts, while reducing foods in high saturated fat like full-fat dairy products, processed and fatty meats, poultry, and skin. Initiating medical management is an additional consideration, partly because highly trained keto-adapted athletes have been found to have elevated LDL cholesterol concentration. It has been argued that the LDL elevation in the context of low carbohydrate and ketogenic nutrition does not confer the same cardiometabolic risk as those who consume higher levels of carbohydrates. See Chapter 4, CVD, for further discussions around the relationship between LDL-C and CVD.
I hope in that chapter they go into some actual numbers, because considering this is a medical textbook, talking about if a rise in LDL-C is a concern, they don't talk about like any numbers, because I would imagine the doctors who are using this diet for their patients would want to know, like, at what point do we get concerned? I'm imagining they would be okay with higher levels than what the guidelines say.
Yeah.
So hopefully it'll go into that.
Okay. So 2.2.3.4, mild side effects and troubleshooting. 2.2.3.4.1, constipation and muscle cramps. Constipation and muscle cramping are the most. Yeah, they are the worst. Constipation and muscle cramping are the most common adverse effects that occur with TCR. Not to be confused with just having less frequent stools, which is common when eating less carbohydrate. Constipation is defined by hard stools or hard to pass stools. Contributing factors include dehydration and, some may argue, decreased fiber intake. Let's see here. See Chapter 8, Gastrointestinal, for further discussion around the conflicting evidence for fiber and constipation. Adequate hydration and sodium intake can frequently effectively prevent or treat constipation. Regular weight-bearing activity is also recommended. Insoluble fiber from low-carbohydrate vegetables, avocado, berries, nuts, seeds, or fiber supplements like psyllium may or may not help with constipation. Stool softeners and osmotic laxatives are other options. Example, milk of magnesia, magnesium citrate, polyethylene glycol, which is Miralax, or lactulose. Stimulant laxatives, for example, bisacodyl sinicides, should be used sparingly due to the risk of bowel hypotonia and dependency with prolonged use. Okay, that's good to know.
What's bowel hypotonia?
Where hypotonia is where you don't have the proper tone, proper like musculature tone of your bowels. So they're not effectively, like your bowels work with peristalsis. So it's like it's squeezing and contracting all the way down and it's pushing that through. So you lose some of that bowel tone. So it's just kind of like, not really doing its thing.
We don't want that.
No.
And working in GI, the doctors they would only tell a patient to take bisacodyl. They really rarely said to take a Senna product, but because you don't want to take those long term at all. It was more like to just jumpstart a colon prep, or if they were needing a quick, they were like really constipated, backed up, but never to take regularly, because it could have you could get more constipated. Your body builds up a tolerance and your bowels stop moving. It initially will stimulate peristalsis, but then like it says, it can create the opposite effect if you use it for too long.
So what my children's pediatrician, because I've had a couple that were chronically constipated, probably from the food they ate, but what they always recommend is doing Miralax twice a day if you're super constipated, twice a day, a cupful for, like a week, and then to do every day like a cupful for a month. And that kind of like retrains your system to get that stuff out of there and to keep it flowing until your body can kind of like readjust, is how I see it, I'm no GI specialist, but that's just personal experience.
Yeah, that's really good advice. And I know that sometimes we would have patients, if they were really backed up, we would have them do a full colon prep.
Yeah.
Just to get things going. But, you got to be really careful. You don't want to, if it's different with people. I think people that are constipated from changing their diet probably just have just a little bit of Miralax would probably be fine.
Yeah. And if you're not like super constipated, you could just do a cup full of Miralax for 7 days and you probably be back on track.
But it's still important to make sure you're drinking plenty of fluid, because Miralax is an osmotic laxative, and so if you're not drinking enough fluid, it's not going to be very effective.
Yeah, because what she means by that is it actually pulls water into the colon to get everything nice and lubricated up, nice and watered down a little bit, and not as hard and dry to pass. So
you got to make sure you got the fluid on board.
Yeah.
Okay, right, that's good to know.
Let's see here. Where was I at? Okay. 2.2.3.4.2 food cravings. Cravings for carbohydrate-rich foods are common upon cessation. Hold on. I just want to say this is not medical advice. Always consult your doctor.
Right.
As two nurses on the internet, we have to protect ourselves. We're not telling anybody to do anything, okay?
Yeah.
I'm just saying.
But keep in mind,
this is over-the-counter stuff that you...
Over-the-counter.
You are welcome to do, but I'm not giving you medical advice. Okay.
Yeah.
Cravings for carbohydrate-rich foods are common upon cessation. For some individuals, the cravings may be very strong, which has led to the concept of processed food addiction. Most foods can be accommodated in small or very small amounts within the overall macronutrient goal, while most milk and dairy products, such as low-fat, non-Greek yogurt, have significant amounts of carbohydrate. Milk substitutes like coconut, almond, or unfiltered milks or Greek yogurt are useful substitutes.
Although I wouldn't do almond milk.
Coconut milk is my favorite. That's my go-to coffee creamer. I use it like in any diet I do. I use that because
almonds, the oxalates, you wouldn't want to do that. But
I mean, I don't worry about oxalates, but some people might. But I don't use almond milk either. So
Yeah, I used to, and I used to like it, but then I'd heard all of the stuff about it, and I haven't used it in years, but I have used coconut milk.
I just don't think anything that's like super unnatural in its form like that. Like, say, imagine the amount of almonds that it's going to take to make milk. Okay.
Right.
Nothing that is in, you should eat things as close to their form as you can. Is there such thing as coconut milk? Yeah.
Yes, absolutely. There is. You can bust that sucker open and get the milk out of it.
Yeah. So, I mean, that was my thinking on that.
Technically not milk.
No, it's the juice. I don't know what it is, but it is good. I used to love it as a kid. Sometimes my mom I would talk her into getting me a coconut at the grocery store, and then we would cut that coconut, and of course there would be the juice or whatever you want to call it in there, and then I would also just eat the coconut. I loved it.
Yes, it is good. And another reason I do coconut milk is because coconut is a natural antifungal. And so my problem has always been chronic candida. So to me, any little thing that I can add to help my chronic candida, I do. So yeah. Anyway,
I didn't know that. I mean, about the coconut being an antifungal. Wow. Is that why people use it? I wonder, for like the pulling, like they'll use that coconut oil or whatever, like for.
I don't know if that's even like a legit thing. I could be wrong, but
I've never done it. I don't know. I've just heard people swear by it, but I was thinking maybe like gingivitis and stuff like that, that you might have in your mouth.
Yeah, I mean, it's a natural antifungal. I'm trying to remember if it's a natural antimicrobial, but I just paid attention to the fungus part because that's the problem that I always have. We could probably
I think it is. I think that it's natural antifungal, antiviral, and antibacterial.
Yeah.
I don't know how strongly it is anti for each of these proportionately.
Yeah. All right, guys, I need to finish reading because my son's getting ready to be out here in a few minutes. But so I'm going to finish this section here. 2.2.3.4.3 halitosis, which ironically most carnivores do not have halitosis.
And I had that at the beginning.
That's one of the first things that I noticed because I used to have the most rank morning breath ever, and my husband would just be like, and it was because I would get these tonsil stones. And so if your breath smells really, really bad, you probably have a tonsil stone or a rotten tooth in there. Like, it's not normal to have rank breath, guys.
Oh yeah. I haven't had a tonsil stone since I started carnivore, but I
haven't either.
I hated them.
Oh yeah. I would wake up in the morning sometimes and I'd be like, and you'd cough it up and it's like, it's death.
Yeah, they're
TMI. I know, but we're not.
But I relate. Same thing would happen. Same thing would happen to me. They're nasty.
Okay, so halitosis in the form of keto breath due to exhalation of acetone can occur with TCR, but it is uncommon. Recommendations to prevent and or mitigate halitosis should include increased water intake, maintaining good oral hygiene, and the use of parsley or sugarless mints or chewing gum. In some cases, modification of macronutrient intake to increase carbohydrate consumption above 50 grams a day may be helpful. So I just have to say about this, hold on, there's my son. Hang on. Hold on, honey, hold on. Okay. I'm still live, Evan. Okay. He's got his headphones on, so I didn't know if you heard me or not. Anyway, I'm almost done, but I just have to say about this, that what was I saying? Oh, I know. With ketosis, I don't notice a like breath, scent like that, and neither does my husband. But what I do notice is my urine. My urine, I can tell every time when I start going into ketosis, my urine smells like, that really strong, just like almost ammonia smell.
Yeah.
Anyway, what about you guys? Anything to add to that?
I had at the very beginning, maybe the first month, I had that keto breath, and it maybe lasted a month or two, but then it went away.
And I had it before, and I will get it intermittently now. So I don't know what that means necessarily, but it's not. I mean, it does, like, it reminds me of like nail polish
Hold
removal,
on,
but it's
guys.
not. I don't think that's the same thing as like, the
Hey guys,
halitosis. Where
I'm sorry, I've got to
it's
go. I'm gonna put it on. I'm gonna stop the cam. I gotta help him with something.
Okay. All right.
So yeah, I don't think it's the same as like just bad breath. You know what I mean? Like when I think of halitosis, I mean, I think maybe that's just a generic term for bad breath. But
yeah,
I think of it though as like what Kim was talking about, where it smells like death and you cough up the little things once in a while.
Stone.
Yeah.
Have you ever had a tonsil stone?
I've had those before. I didn't know that that's what it was until y'all just started talking about it. I had no idea. And I've had them. It's been a long time since I've had one, but I mean, I have remembered coughing that up and going, oh my God, what is that?
You think it's like a little piece of bread or something. You think it's like a piece of bread or something that gets stuck in there, but it's actually bacteria.
Oh my gosh. See, I had no idea what it was. I just knew that it stunk. And it's not like all the time or anything. It's been a while since I've had that happen, but I have had it happen before and I just didn't know what it was. And it was terrible. I mean, it was just gross. I mean, it wasn't like agony or anything, but it was just gross.
Well, but it's irritating because you could feel it in the back of your throat, stuck there, And I remember, I would look up, how to get rid of them, and there was all these recommendations, and some of them included like sticking something back there and pulling it out. But I've got a horrible gag reflex.
Oh gosh, no, I couldn't do that.
Yeah, there's no way. But I would do the gargles and try to do something to dissolve it. But it would be like it's not coming out until it wants to. I think the gargles sometimes would help a little bit to kind of dissolve it a little, and so it could kind of dislodge. But oh no, that's one of the things, with all the benefits I've had from going carnivore, the lack of tonsil stones is up there. I mean, it may seem silly, but those are horrible.
I don't remember of necessarily feeling anything in there, but I just remember, like I said, once in a blue moon, coughing one up and just being, what is this? This is nasty, and not knowing what it was. So I didn't know that was what it was until just now, till talking to y'all. I didn't know what it was.
Hey guys,
you got the last paragraph?
Yep.
Hey guys, I have to go. My son thinks he's lost his iPad. It's actually in his backpack in the truck. So I've got to go hunt him down because he just ran back into college.
Okay.
So
I'll just do
I have to go. I'm sorry.
I'll just do the last paragraph and then we'll wrap up. Awesome. All right. See you later.
Okay. Bye, guys. I'm sorry.
Bye.
No, it's okay.
Bye. It's all right. Okay. So conclusion. The last part was just the conclusion. So
so that's no big deal.
So most troubleshooting on TCR, while common, is easily remedied with simple dietary changes. Contraindications are relatively uncommon. For example, inborn errors in metabolism, which was that chart we looked at. But they are still important to avoid patient complications. And the majority revolve around careful monitoring and or discontinuation of medications such as insulin and insulin secretologues. Importantly, LDL-C increases in many patients, if observed, do not inherently translate to atherogenic risk due to the myriad significant improvements in other risk avenues. For example, coronary artery calcium, glycemic control, HDL-C, and triglyceride concentrations, blood pressure, etc. And require careful assessment to avoid unnecessary and or deleterious modification. These warnings should be weighed against the significant benefits of TCR. Okay, so I'm kind of reading that as even if your LDL cholesterol increases a lot, you should not just look at it independently.
Right.
That, you'll need to look at it with all of these other things that improve. And so you're looking at your overall risk, right? So all these other things improve and you got your LDL cholesterol that went up. That's not necessarily a problem. especially like I'd say, get that fractionated LDL like I got. You can see that you got it's the big fluffy particles. My little small dense particles are really low. So, yeah.
It's kind of like that meme I saw the other day, and I don't remember who posted it. It was probably Dave Mack, but it could have been somebody else. But it was a picture of a person talking to their doctor, and they were saying, well, your A1C is better, your glucose is better, you've lost 100 pounds, blah blah blah, but we've got to give you a statin for that LDL, and it's just like
yeah.
I mean, they picked the one thing,
Anyway. And cholesterol is so good for so many things in our bodies that, I would be so much, I want my cholesterol to be a little bit higher because I mean, I lost my mom to Alzheimer's and she was dealing with it for 11 years and it was horrible. And I don't want to have to deal with that. I mean, if I could do something to avoid getting dementia and Alzheimer's, and it has to do with cholesterol and your cholesterol that's so important for your brain, then I'll take the cholesterol. Yeah.
I will too.
Yeah.
I will too.
All righty. Well, it's been a quiet audience today, which is fine. So just for those of you who are here or watching on the replay that are part of our book club, just wanted to remind everybody we are wrapping up our book, Good Energy. We are not finishing it completely. We're just going to do chapter 9. The last part of it is very individualized checklists, recipes, way to implement the things that we're taught. And we have been doing this book long enough. We're ready to finish it. And we are going to take a break on the book club through the holidays. So we will regroup and figure out what we want to do after the new year. And it might be a different day. We'll see.
But for this one, we're still doing the Keto Study Club every Thursday, same time, same channel.
We're having a good time.
Yes.
Learning a lot. So, all righty. Very good. Well, I will go ahead and sign off for today. Hope everyone has an absolutely wonderful day.